Welcome to Pediatric Case Review. Today we'll explore aortic regurgitation in the pediatric population. This comprehensive lecture is designed for general pediatricians to enhance recognition, evaluation, and management of this important cardiac condition. Let's begin our journey through the pathophysiology, clinical presentation, diagnostic approach, and management options. Number: a 10-year-old boy presents with a history of recurrent fever, joint pain, and a newly discovered cardiac murmur. What is the most likely etiology of aortic regurgitation in this patient? Is it A, rheumatic heart disease, B, congenital bicuspid aortic valve, C, Marfan syndrome, or D, trauma? The correct answer is A, rheumatic heart disease. The history of recurrent fever and joint pain suggests rheumatic fever, which remains a significant cause of aortic regurgitation in pediatrics globally. Other important causes include congenital bicuspid aortic valve, which is the most common congenital cardiac anomaly, and connective tissue disorders like Marfan syndrome, which typically presents with additional skeletal findings. In chronic aortic regurgitation, the heart undergoes specific adaptations to compensate for the hemodynamic changes. What is the primary compensatory mechanism that occurs in chronic aortic regurgitation? Is it A, left ventricular hypertrophy, B, right ventricular hypertrophy, C, pulmonary hypertension, or D, atrial fibrillation? The correct answer is A, left ventricular hypertrophy. In chronic aortic regurgitation, the left ventricle adapts to volume overload by developing eccentric hypertrophy. This allows the ventricle to accommodate larger volumes while maintaining adequate cardiac output. However, this compensation has limits, and without intervention, progressive dilation eventually leads to systolic dysfunction and heart failure. A 7-year-old girl with mild aortic regurgitation is being evaluated in your clinic. Which of the following symptoms is least likely to occur in mild to moderate pediatric aortic regurgitation? Is it A, asymptomatic presentation, B, exercise intolerance, C, palpitations, or D, angina? The correct answer is D, angina. Mild to moderate aortic regurgitation in children is typically asymptomatic. When symptoms develop, they usually begin with exercise intolerance and fatigue, progressing to dyspnea with exertion. Palpitations may occur with arrhythmias. Angina is rare in pediatric patients and generally only occurs in severe, long-standing cases with significant left ventricular dysfunction. You are performing a physical examination on a child with suspected aortic regurgitation. Which of the following physical findings is most specific for aortic regurgitation? Is it A, wide pulse pressure, B, holosystolic murmur, C, early diastolic decrescendo murmur, or D, mid-systolic click? The correct answer is C, early diastolic decrescendo murmur. This high-pitched, blowing murmur is best heard at the left sternal border with the patient leaning forward and in deep expiration. While wide pulse pressure and bounding pulses are common in aortic regurgitation, they are less specific. Holosystolic murmurs typically indicate mitral regurgitation, while mid-systolic clicks suggest mitral valve prolapse. Several eponymous physical examination signs have been described in aortic regurgitation. Which of the following eponymous signs is not associated with aortic regurgitation? Is it A, Corrigan's pulse, B, de Musset's sign, C, Kussmaul's sign, or D, Dirizia's sign? The correct answer is C, Kussmaul's sign. Kussmaul's sign, which is paradoxical jugular venous distension during inspiration, is associated with constrictive pericarditis and right heart failure, not aortic regurgitation. The classic signs of aortic regurgitation include Corrigan's pulse, which are water hammer or collapsing pulses, de Musset's sign, characterized by head bobbing with each heartbeat, and Dirizia's sign, which is a to and fro murmur heard over the femoral artery. An 11-year-old patient presents with suspected moderate aortic regurgitation based on physical examination. What is the gold standard diagnostic tool for confirming and grading the severity of aortic regurgitation? Is it A, electrocardiogram, B, chest X-ray, C, echocardiography, or D, cardiac catheterization? The correct answer is C, echocardiography. Echocardiography is the gold standard for diagnosing and grading aortic regurgitation in pediatric patients. It allows visualization of valve morphology, measurement of regurgitant jet characteristics, and assessment of ventricular dimensions and function. While electrocardiogram may show left ventricular hypertrophy and chest X-ray might demonstrate cardiomegaly in advanced cases, these are nonspecific. Cardiac MRI provides excellent quantification but is generally reserved for cases where echocardiographic findings are inconclusive. A 9-year-old with chronic severe aortic regurgitation undergoes an electrocardiogram. Which finding would you most expect to see on the ECG? Is it A, right ventricular hypertrophy, B, left ventricular hypertrophy, C, right bundle branch block, or D, first-degree atrioventricular block? The correct answer is B, left ventricular hypertrophy. In chronic severe aortic regurgitation, the left ventricle experiences volume overload leading to eccentric hypertrophy. On ECG, this manifests as left ventricular hypertrophy with increased QRS voltage in left-sided leads. Additional findings may include ST segment depression and T-wave inversions in lateral leads. Chest radiography typically shows cardiomegaly with left ventricular prominence and sometimes dilation of the ascending aorta, especially if there is aortic root pathology. A 12-year-old with moderate aortic regurgitation has normal left ventricular size and function on echocardiography and remains asymptomatic. Which medication is most appropriate for this patient? Is it A, digoxin, B, beta blocker, C, angiotensin-converting enzyme inhibitor, or D, no medication needed? The correct answer is D, no medication needed. Asymptomatic pediatric patients with moderate aortic regurgitation who maintain normal left ventricular size and function typically require observation rather than medical therapy. While ACE inhibitors or ARBs may be considered in adults with severe regurgitation or declining ventricular function, their routine use in asymptomatic children lacks strong evidence. Endocarditis prophylaxis guidelines have changed over time, and current recommendations should be followed for specific high-risk situations. A 14-year-old with severe aortic regurgitation has a left ventricular end-diastolic dimension Z-score of plus 3.5 and an ejection fraction of 55%. What is the most appropriate management approach? Is it A, continue medical therapy, B, balloon valvuloplasty, C, surgical valve repair, or D, surgical valve replacement? The correct answer is C, surgical valve repair. This patient has severe aortic regurgitation with significant left ventricular dilation, indicated by the Z-score greater than 3.5. Surgical intervention is indicated even with preserved ejection fraction. In pediatric patients, valve repair is preferred over replacement whenever anatomically feasible to avoid anticoagulation and allow for growth. Balloon valvuloplasty is not effective for aortic regurgitation, as it typically worsens the regurgitation. When considering surgical options for pediatric aortic valve disease, which of the following has the lowest risk of requiring reoperation? Is it A, Ross procedure, B, mechanical valve replacement, C, bioprosthetic valve replacement, or D, valve repair? The correct answer is B, mechanical valve replacement. Mechanical valves offer the greatest durability and lowest reoperation rate, but require lifelong anticoagulation. The Ross procedure, which uses the patient's pulmonary valve to replace the aortic valve, offers growth potential and avoids anticoagulation, but carries risk of both autograft and right-sided conduit failure over time. Bioprosthetic valves undergo accelerated calcification in children and typically fail within 5 to 7 years. Valve repair has the lowest initial surgical risk, but often requires reoperation as the child grows. A 6-year-old with mild aortic regurgitation has normal left ventricular dimensions on echocardiography. What is the most appropriate follow-up interval for echocardiographic monitoring? Is it A, every 1 to 2 months, B, every 6 months, C, annually, or D, every 2 to 3 years? The correct answer is C, annually. For a pediatric patient with mild aortic regurgitation and normal ventricular size, annual echocardiographic follow-up is typically appropriate. Patients with moderate regurgitation generally require evaluation every 6 months, while those with severe regurgitation should be seen every 3 to 6 months. The follow-up interval should be adjusted based on symptoms, ventricular size and function, and progression rate. Clinical evaluation between imaging studies is also important to monitor for development of symptoms. An 8-year-old competitive athlete has moderate aortic regurgitation with normal left ventricular size and no symptoms. What is the most appropriate exercise recommendation for this patient? Is it A, no restrictions, B, avoid competitive sports, C, light aerobic activity only, or D, complete exercise restriction? The correct answer is A, no restrictions. According to current guidelines, asymptomatic patients with moderate aortic regurgitation and normal left ventricular size can typically participate in all competitive sports without restriction. Activity limitations become necessary when there is severe regurgitation, significant left ventricular dilation, or symptoms with exertion. However, management should be individualized, and patients should be regularly reevaluated as the condition may progress over time. A teenager has had untreated severe aortic regurgitation for many years. Which complication is this patient most likely to develop? Is it A, pulmonary hypertension, B, left ventricular systolic dysfunction, C, atrial fibrillation, or D, aortic dissection? The correct answer is B, left ventricular systolic dysfunction. The natural history of untreated severe aortic regurgitation involves progressive left ventricular dilation due to chronic volume overload, eventually leading to systolic dysfunction that may become irreversible. While pulmonary hypertension can develop in end-stage disease, it's not typically an early complication. Atrial fibrillation is more common with left atrial enlargement, as in mitral valve disease. Aortic dissection is associated with certain etiologies of aortic regurgitation like Marfan syndrome, but is not a direct complication of the regurgitation itself. A 13-year-old with Marfan syndrome has moderate aortic regurgitation. Which additional monitoring is most important in this specific patient? Is it A, coronary angiography, B, Holter monitoring, C, aortic root dimensions, or D, pulmonary function tests? The correct answer is C, aortic root dimensions. In patients with Marfan syndrome, progressive aortic root dilation is the primary concern and requires close monitoring. Aortic regurgitation in these patients is often secondary to annular dilation rather than primary valve pathology. Beta blocker therapy is typically recommended to slow aortic root growth. Other conditions requiring special consideration include bicuspid aortic valve, Williams syndrome, and Turner syndrome, each with unique monitoring and management approaches. Standard aortic regurgitation guidelines must be adapted based on the underlying condition. According to current guidelines for managing pediatric aortic regurgitation, which of the following is not an indication for surgical intervention? Is it A, symptoms attributable to aortic regurgitation, B, left ventricular ejection fraction less than 55%, C, left ventricular insystolic dimension z-score greater than 3, or D, mild aortic regurgitation with normal left ventricular dimensions? The correct answer is D, mild aortic regurgitation with normal left ventricular dimensions. Current guidelines do not recommend intervention for mild aortic regurgitation with normal ventricular size. Surgical intervention is indicated for symptomatic patients, those with left ventricular dysfunction or significant ventricular dilation. Pediatric guidelines emphasize the importance of z-scores rather than absolute dimensions to account for body size differences. The threshold for intervention tends to be lower in children than adults to prevent irreversible myocardial damage during critical developmental periods. Thank you for joining Pediatric Case Review for this comprehensive exploration of aortic regurgitation in pediatric patients. Remember that early detection through careful auscultation, appropriate imaging, and regular follow-up is essential for optimal management. The decision for intervention requires balancing the risks of surgery against the potential for irreversible myocardial damage. Please follow our channel for more informative presentations on pediatric conditions. If you have questions, please leave them in the comments section below. We appreciate your support and commitment to pediatric education.